Welcome to your custom deep dive for Saturday, April 4, 2026. Usually when we talk about a medical diagnosis, there's this expectation of precision.
Oh, absolutely. We find a lot of comfort in diagnostic clarity.
Right. You break your arm, the x-ray shows a jagged white line, and the doctor just points at it and says, there it is. That's the problem. It's totally binary.
Yeah, we want the physical evidence to match the patient's symptoms perfectly. We like things visible and neatly categorized.
But then you step into the world of women's health and chronic pain, and suddenly that neat binary x-ray machine feels like it's entirely broken.
It really does. The diagnostic landscape just becomes incredibly murky.
Exactly. And the assumptions we rely on just start to fall apart.
Which brings us to our mission for today's deep dive. We are exploring a really fascinating 2024 medical review from the journal Diagnostics.
Yes, looking specifically at adenomyosis in adolescents.
Right. So whether you are a medical professional or maybe someone navigating your own health journey or just deeply curious, we are tracking a massive paradigm shift today. A huge one, yeah. It changes how we view chronic pain entirely.
We're looking at how a disease historically believed to only affect women over the age of 40 is now being discovered in teenagers.
Yeah.
Okay, let's unpack this. Because to understand why finding this in teenagers is such a monumental shift, we first have to look at why doctors missed it for, well, over 160 years.
Yeah, the timeline here is a perfect case study in how medical knowledge is limited by the tools available at the time. I mean, the condition was actually first described way back in 1860 by von Rokitansky.
A pathologist, right?
Right. He was looking at tissue under a microscope and observed something highly unusual. He saw the soft, gland-like tissue that is supposed to form the inner lining of the uterus, the endometrium, somehow trapped deep inside the dense muscular outer wall.
The myometrium. So to visualize this, it's tissue that belongs on the surface, somehow growing deep inside the dense muscle itself.
Exactly. And that misplaced tissue creates profound structural problems. But the historical catch here is who was diagnosed with it.
Right, the demographic.
For over 100 years, the absolute medical consensus was that adenomyosis was strictly a disease of older women, specifically women over 40 who had given birth multiple times, multiparous women.
I was reading about why they believed that, and it is just the ultimate example of survivorship bias in medical data.
It really is.
It wasn't because the disease only spontaneously appeared in older women. It was because the only way to definitively diagnose it was to physically remove the uterus through a hysterectomy.
Right, you had to slice the tissue and examine it under a microscope. You could only find the disease if you actually removed the organ.
And the only demographic routinely getting hysterectomies for severe pelvic pain were women over 40 who had already completed their families.
Exactly. Adolescents and young women with the exact same severe pain were obviously not getting hysterectomies. So their uteruses were never examined under a microscope.
It's like assuming airbags only deploy for people over 40, simply because you only bothered to check the cars of people over 40.
Yeah.
We only found it in older women because they were the only ones getting the surgery.
What's fascinating here is how modern technology completely shattered that bias. In the last decade or so, advancements in non-invasive imaging allowed us to finally look deeply inside intact uteruses.
You're talking about high-resolution ultrasound and MRI?
Yeah,
Right.
exactly. When we turned those advanced imaging machines on much younger patients, the entire medical paradigm just collapsed. We realized this is not a disease of aging at all.
It has an early onset.
Right, beginning right in adolescence. It simply progresses and worsens over time until it eventually leads to those hysterectomies later in life.
Wow. So now that imaging allows us to see this happening in teenagers, we have to look at the mechanics. Like, how does tissue that belongs on the inner lining end up migrating deep into the muscle wall?
Well, the current understanding points to a dual mechanism. You can think of it as an issue with both the seed and the soil.
Okay, the seed and the soil. Let's start with the seed.
First, there are genetic mutations like KRAS and PI3CA that occur in the cells of the uterine lining. These mutations give those specific cells a hyperproliferative ability.
Meaning they divide and grow way faster and more aggressively than normal cells.
Precisely. But aggressive cells aren't enough on their own. They need a permissive environment to take root. That's the soil.
So the teenager's internal chemistry has to actively support that rogue growth.
That is where the local environment comes into play. These young patients often experience epigenetic changes that create localized estrogen dominance.
So too much estrogen and a reduced sensitivity to progesterone.
Right, and this specific hormonal imbalance acts like a fertilizer. It allows those mutated cells to survive and thrive deep inside the muscle tissue where they do not belong.
And once that ectopic lesion forms, it just does what endometrial tissue is biologically programmed to do, right? It bleeds in rhythm with the monthly menstrual cycle.
Yes. But because those cells are buried inside a dense muscle wall, that monthly bleeding has absolutely nowhere to go.
The blood is just trapped inside the muscle tissue. That sounds excruciating.
It is. And it initiates a devastating cycle known as tissue injury and repair, or TIR. The body perceives that trapped blood as a microscopic internal wound.
So the immune system sends in specialized cells to clean it up and heal the injury.
Exactly. But because the bleeding happens again the very next month, the wound never truly heals. It becomes a site of constant chronic inflammation.
And over time, that repetitive cycle of injury and attempted repair has to alter the structure of the muscle, right?
It completely alters it. The soft, flexible tissue is slowly replaced by rigid, fibrous scar tissue.
Okay, I understand how that cycle of scarring happens once the cells are already in the muscle. But I was reading the source material regarding the newer theories on how those cells get there in the first place, specifically the Schwann cell theory. And honestly, I got pretty lost.
It's a very dense concept, I admit.
Because Schwann cells insulate peripheral nerves, right? Wait, are you telling me that cells designed to insulate nerve endings are essentially having an identity crisis and transforming into uterine lining?
That is exactly what the new research suggests. It is a profound concept that challenges how we think about cellular biology.
Walk me through that. How does that even happen?
Well, the boundary where the inner lining meets the muscle wall is incredibly complex. It's heavily innervated by tiny peripheral nerves, and those nerves are wrapped in Schwann cells.
Right, which act like the rubber insulation around a copper wire.
Perfect analogy. When that boundary layer experiences chronic injury like from the constant inflammation we just discussed, those insulating Schwann cells do something remarkable. They undergo a process called dedifferentiation.
Dedifferentiation, so they lose their specialized traits.
Yes, they strip off their traits as nerve insulators and revert to a more primitive, blank slate state.
Wow.
And then, driven by the high levels of estrogen and inflammatory cytokines in the area, these blank slate cells undergo transdifferentiation. They assume an entirely new identity, turning into endometrial cells right there inside the muscle.
So the body's own localized repair mechanism is accidentally generating the very cells that cause the disease.
Yeah.
That is wild.
It really is a biological perfect storm.
So if there is constant internal bleeding, nerve inflammation, and scarring happening in a teenager's muscle tissue, what does that actually look like for them day to day?
Well, it's important to note from the data that roughly 1/3 of these cases are entirely asymptomatic.
Really? A third of them feel nothing.
Yeah, the body manages the ectopic tissue without outward signs. But for the rest, the impact on their quality of life is massive. The hallmark symptom is debilitating pelvic pain, specifically dysmenorrhea.
The clinical term for painful periods.
Right, and we have to make a careful distinction here between primary and secondary dysmenorrhea. Primary dysmenorrhea is functional pain. The reproductive system is working normally, but the natural cramping is painful, usually mild to moderate.
But secondary dysmenorrhea means there is an organic cause, an underlying physical pathology.
Exactly. And the pain from secondary dysmenorrhea is typically severe. We're talking a score of over 7 on the visual analog scale.
Severe meaning pain that drastically interferes with a teenager's ability to function, go to school, or just live a normal life.
Yes. And alongside that pain, the review highlights heavy menstrual bleeding, or HMB, as the other critical early onset symptom.
In the past, when adolescents went to a doctor with severe, incapacitating cramps and heavy bleeding, they were just dismissed, right? Told it was a normal part of puberty.
Constantly. They were told their bodies would eventually regulate. But the clinical data we have now tells a completely different story.
Yeah, the prevalence numbers in the review are a massive wake-up call. If you look at a general adolescent population, ultrasound signs of this disease might show up in roughly 5.2% of teenagers.
Which is already higher than most people would guess.
Right. But if you filter that group and only look at teens who report severe debilitating pain, the prevalence jumps to 18.1%.
A huge jump.
And if a teen has both severe pain and heavy menstrual bleeding, their odds of having this disease skyrocket to over 25%, up to 27.4% in some data. So what does this all mean?
It means we have to stop normalizing their pain.
Exactly. For you listening, it means that killer cramps are not a normal teenage rite of passage. They are a blaring statistical alarm that something structural might be happening.
The presence of those symptoms absolutely demands clinical investigation. But what makes this so tricky to manage is that the physical severity of the disease on a scan doesn't always align perfectly with the intensity of the symptoms.
Wait, really? So you could have a lot of pain, but not a lot of visible disease?
Yes, you could scan a patient with a very mild localized lesion who's experiencing agonizing 10 out of 10 pain. Conversely, you might see a severely scarred, enlarged uterus in a patient who reports only moderate discomfort.
So a doctor cannot dismiss a teenager's pain just because an initial scan doesn't look catastrophic.
Never. The clinical suspicion has to remain high.
Which brings up a practical question. If the symptoms overlap with so many other issues, how does a doctor today actually prove what it is without reverting back to the old method of cutting the patient open?
It requires a meticulous differential diagnosis. The physician must distinguish it from uterine fibroids, which are benign, smooth muscle tumors.
How do they look different on a scan?
Well, fibroids are typically encased in a distinct capsule. Adenomyosis lesions, on the other hand, blend directly into the surrounding muscle without a clear border.
Okay. And they also have to screen for endometriosis, right?
Yes, which is a separate condition where the uterine lining grows entirely outside the uterus, often on the ovaries. Crucially, endometriosis actually coexists with adenomyosis in about 3 to 10% of cases.
That definitely complicates the clinical picture. To navigate that, the review positions ultrasound as the absolute first-line diagnostic tool.
Specifically, high-resolution transvaginal or transrectal ultrasound. The 2015 and 2022 MUSA consensus groups have established formalized criteria for sonographers. They look for direct and indirect signs.
Direct signs meaning they actually see the misplaced tissue.
Right. They literally see tiny, fluid-filled myometrial cysts or bright white, hyperechogenic islands of tissue inside the muscle.
And the indirect signs are the structural changes the disease forces upon the entire organ.
Exactly. The uterus might become enlarged and globular. You frequently see asymmetrical thickening where one side of the wall is much thicker than the other because of the scarring.
There's also that distinct visual artifact on the ultrasound, right? The fan-shaped shadowing.
Yes, caused by the ultrasound waves interacting with the dense fibrotic tissue.
But if the ultrasound doesn't provide a clear answer, the review mentions MRI as the second-level tool. What is the MRI looking for that the ultrasound might miss?
MRI is exceptional at looking at the junctional zone. This is the highly specialized inner third of the muscle wall. In a healthy organ, it's thin and sharply defined.
But in adenomyosis,
The constant invasion of cells causes this zone to thicken. If an MRI reveals a junctional zone thicker than 12 millimeters, it is a highly reliable indicator of the disease.
there was also a newer diagnostic tool mentioned that fascinated me: elastography.
Oh, elastography is brilliant.
I love it because it relies on pure physics. It maps the physical stiffness of the internal tissue. It's like squeezing an avocado at the grocery store. You can't just look at the outside to know if it's ripe. You have to test the density to know what's going on inside.
That's a great way to picture it. Elastography does that internally. Because adenomyosis involves soft glandular tissue, it registers as much softer on the scan than the hard, dense tissue of a fibroid.
But there is a caveat to all this amazing technology, isn't there?
There is. While the technology is amazing, we're talking about an 89% sensitivity for ultrasound, it is entirely operator dependent. You need an expert sonographer who knows exactly what to look for. And honestly, there is still no universal consensus on exactly how many ultrasound features must be present to confirm a definitive diagnosis.
So the tech is there, but the standardization is still catching up.
Precisely.
Here's where it gets really interesting, though. We have spent this entire time looking very closely at the uterus, but the data suggests this disease might be communicating with the patient's entire systemic immune system.
The systemic implications are staggering. We are seeing a high correlation with broad autoimmune diseases.
Like what?
Well, autoimmune thyroiditis appears in about 10 to 15% of these patients compared to 3 to 8% normal. Rheumatoid arthritis affects roughly 20% of them. There are also verified links to systemic lupus erythematosus and inflammatory bowel disease.
I am struggling to connect those dots. How does a localized problem in the pelvis trigger a systemic autoimmune response, like rheumatoid arthritis?
It comes back to how the body perceives that misplaced tissue. Because those cells are buried in the muscle, the immune system flags them as a foreign invader, an antigenic stimulus.
So a body mounts an attack.
Right, it sends inflammatory markers to the site. But because the tissue never leaves, the immune system's alarm never turns off. It creates a state of chronic localized inflammation, elevating cytokines like IL-6.
Over months and years, that has to exhaust the immune system.
It does. The proteins responsible for maintaining immune tolerance, like HLA-G, begin to alter and fail.
If we connect this to the bigger picture,
Exactly. If we connect this to the bigger picture, that chronic inflammatory burden fundamentally alters how the immune system behaves. While diseases like rheumatoid arthritis typically fully manifest in adulthood, the shared genetic susceptibilities and inflammatory pathways are actively brewing during these teenage years.
knowing all of this, the mechanism, the severe pain, the immune factors, what can a doctor actually do for a 14 or 16-year-old sitting in their office today?
It is a delicate clinical dilemma. The goals are twofold: relieve the immediate symptoms and preserve their future fertility.
Since the disease is driven by the menstrual cycle and estrogen, I assume the first line of defense is hormones.
Yes, central suppression of hormones, typically using continuous oral contraceptives. The goal is to completely stop the cycle of bleeding and repair.
Starve the ectopic tissue of the signals it needs to bleed.
Right. But if that fails, there are stronger medications, like GnRH agonists, that temporarily shut down the ovaries entirely.
Hold on. If we aggressively suppress estrogen in a teenager, doesn't that mess with their bone development? They haven't even hit their peak bone mass yet.
You've hit on the exact tightrope doctors have to walk. Peak bone mass isn't achieved until the early 20s. If you drastically reduce estrogen during adolescence, you risk stunting that vital bone development.
Setting them up for postmenopausal style osteoporosis in their 20s.
Here, exactly. So balancing the suppression of the disease against those skeletal risks requires extreme caution.
What about surgery? If there's a lesion causing pain, why not just surgically remove it?
In adolescence, surgery is highly debated. The disease is often diffuse, interwoven throughout the entire muscle wall. If a surgeon just cuts out a specific nodule, they are only removing a symptom, not the predisposition.
So the recurrence rate is high.
Incredibly high. Surgery is only used for very rare refractory focal lesions where the surgeon can spare the rest of the uterine cavity. For most teens, it's just not a viable option.
Which really emphasizes why early, non-invasive ultrasound diagnosis is so absolutely vital.
Yes, catch it early, and you can initiate safer medical management to suppress it.
We have covered an incredible amount of ground today. From a disease that only existed in older women to a highly complex immune-linked condition actively developing in teenagers. We've talked about Schwann cells having identity crises, the avocado-squeezing physics of elastography, and the tightrope of treating severe pain without compromising bone density. It is a vital reminder to listen to our bodies and never dismiss severe pain as normal.
This raises an important question, one that builds on everything we've discussed today. If adenomyosis was hiding in teenagers for over a century simply because we didn't have the ultrasound technology to look for it, what other chronic, aging-related diseases are secretly brewing in adolescents right now, just waiting for the next leap in medical imaging to be discovered?
What a profound thought to end on. Thank you for joining us on this custom deep dive. Keep questioning the consensus, keep learning, and as always, keep diving deep.